Did it advance there, Aaron? Yeah.
Yeah, is it going, do you want to keep going past this slide or is it stuck?
The slide I'm looking at says disclosures, but
okay, you're good. It advanced.
Okay, good. All right. So these are my disclosures, nothing current. So this is what I heard after many cases during my residency. Nate, you did that very well, but you need to work on your efficiency. So from my perspective, that was my attendings just telling me you're really slow, which I was okay with because I was trying to learn how to do it right before I learned how to do it, efficiently. But this is, this is really my heritage, is surgical inefficiency. So this is something that has deep personal meaning to me in many ways, and I'm excited to kind of share my views on it, where I've taken it. So why am I interested in surgical efficiency? Well, first, professional curiosity. I have now been a part of 5 academic medical institutions with different phases in training, and then being an attending. And it's just fascinating to me that it can like reliably take one surgeon an hour and 45 minutes to do a cholesteatoma surgery, and another surgeon 3.5+ hours to do a very similar surgery. Now, I'm not saying outcomes are always 100% equivalent for all surgeons. That's a more challenging subject really to look at, to be honest, than what I've been looking at. But it's just at face value, it's just really interesting to me. And I wonder why. I wonder how those differences arise and what they could mean. Secondly, I'm interested just for personal goals. We've heard the old adage, a penny saved is a penny earned. But from my perspective, an hour saved is an hour earned. And I don't have a goal to be the fastest surgeon. I know I am in an academic institution. I train residents. If you look at the literature, residents add between 34 to 58 minutes to an otologic case, just on average. There's a couple studies that have looked at that. So it's not really about trying to be the fastest surgeon ever. It's mostly trying to be the best version of myself that I can be, for my skill set and for the institution in which I work. Third, from a systems or community standpoint, I think that there are implications of efficiency to burnout. There's a lot of issues that involve burnout. There's a lot of issues that involve efficiency, but I don't think there's any doubt that when you're somewhere, not naming any names, but it may be the place that you say Dr. Meyer is stuck at right now, but there are some places where efficiency is just completely a lost cause. And there's something that's, no matter what you're doing, no matter how you're being paid, no matter how you're training people, no matter what research you're getting out of, there's something that is quite maddening about doing something in much longer time than that thing should take. And so I can't help but think that there are some implications to burnout when you look at efficiency. $4.6 billion is the estimated annual cost of burnout in the United States alone, with physicians switching jobs or quitting medicine, recruiting new physicians, and all of the other expenses that go along with that. So that's a third reason to be interested in this. So from a causes, just delving a little bit more into this, causes of physician burnout per the AHRQ, the one that these are just some different causes, proposed, theorized causes, and these are some proposed solutions. And where efficiency comes in is usually a little bit more on kind of the prioritized work-life balance that you see in the top right of the screen there. When you look at pressures on surgical time, I think this helps us figure out kind of why people land where they land. There's a famous investor, Charlie Munger, who was Warren Buffett's partner, who said, show me the motivation, and I'll show you the result. So basically, like, what are people being incentivized to do? And that can often tell you how it ends up getting done. So when you look at the different players involved in what goes on in an operating room, you look at physicians, you look at health systems, you look at insurers, and there are some factors that actually favor longer surgery. So there are time pressures on physicians, as all the physicians on this call know, but the time pressure can make us feel less like doing more surgery in less time. Just like we don't like being told we need to see more patients in less time in clinic. In some ways, it can be challenging to be told that you need to do more surgeries in less time. So that would be something that would potentially favor longer surgery. From a teaching standpoint, if you're trying to do a tympanoplasty in 25 minutes versus taking an hour and a half to do it, that's something that's going to put pressure on your ability to teach someone else to do it well. And so from that perspective, if you can just spend as long as you want, then it would be more convenient from a teaching standpoint, particularly for those of us who teaching is a big part of what we do. From a health system standpoint, there are some reimbursement paradigms, particularly fee for service. And I don't actually know enough about the differences to tell you more specifically than that. But I do know that there are some reimbursement paradigms that actually reimburse the operating room for dollars per minute. That cost is either passed on to the insurer or it's eaten by the health system. And when it's passed on to the insurer, then having a longer surgery, although you're using more resources from a nursing and anesthesia standpoint, you're still probably coming out ahead. So that would be a health system factor that favors longer surgery. I don't really think there's any factors where insurers are favoring longer surgery. So from a favoring shorter surgery standpoint, from a physician standpoint, reimbursement under at least a fee-for-service model is going to favor shorter surgery. If you are reimbursed the same amount for your surgery, no matter if it's 3 hours or 3 minutes, then you are going to probably try to do as many surgeries as you can in the same amount of time. From a health system standpoint, patient access has always been a big marker of efficiency of a health system. And if you as a physician are doing 5 cochlear implants in a day versus 3 cochlear implants in a day, that's going to have a big impact on your patient access for the operating room. Sure, OR availability, number of OR days per week, those things can also be choke points. But ultimately, what it comes down to, also another contributing factor, is that the amount of time you take per case also dictates your patient access in many ways. From a reimbursement standpoint, if you're being reimbursed by an accountable care organization or via a DRG, a diagnosis-related group, you, as a health system, you're getting paid basically one lump sum to take care of a particular patient for a particular problem. And if you can do that by using fewer resources, part of which is OR nurses, anesthesiology teams, things like that, if you can do that in less time, therefore you are paying them less, then your health system would see a greater profit. So that would favor shorter surgery as well. From an insurer standpoint, if they're paying in a model where the cost of the OR is passed on to them, then they're going to have an incentive to try to keep that cost as low as possible. By the way, just interrupt me anytime during this talk if any of you guys have questions, please, so we can just address them as we go. I'm also, of course, happy to take questions at the end. So we're going to get a little bit into the background, the question background of why I got interested in this and how some of this came to be. So When I got to UK just over 3 years ago, I did what any good junior faculty will do is I try to pivot off of things that people around me were doing well. And so a lot of you on this call, at least a few of you on this call, know Matt Bush, who was my senior partner when I joined and now is my chair. And he had been looking at basically access and healthcare disparities in hearing related healthcare. And he had been doing it very well for many years. And so I tried to pivot off a little bit of what he had done really well. And then also just try to leverage what was unique about the institution that I was at or the region in which I practiced. So this is a map of what's called Appalachia or the Appalachian region, and it's centered around the Appalachian mountains that run from, outcrops of which run from Mississippi all the way up into New York. And it's a region that's characterized by poverty, poor education, unemployment, and delayed access to healthcare. There's a lot of data that shows that rurality-associated delays in access to care are associated with advanced disease stage at initial presentation in many clinical entities, a variety of types of cancer, appendicitis, things like that. And then one of these studies, at least, was Matt Bush's, looking at kids with chronic seborrheic otitis media and cholesteatoma. They exhibit decreased healthcare utilization. They present with cholesteatoma at a higher rate, and they suffer more frequent and robust clinical complications. So my first question was, do patients from rural areas with chronic ear disease fare differently than their more urban counterparts? So for this study, we looked specifically at patients that had cholesteatoma only. And then as a proxy for severity, we used rate of canal wall down surgery and surgical time. So we had 600 patients that were undergoing a primary tympanostoid for an indication of cholesteatoma. And we used a mixed effects regression and adjusted for the patient age, BMI, sex, and surgeon. To do that, we used this rural-urban continuity codes by county to divide up the counties by whether they were coming from a metro area or a rural area or a very rural area. And the criteria for these are listed on the left here. It has to do with how many people are in the county and then how adjacent the county is to a metro area. And so this is what the United States uses for evaluating the rurality of different regions. So we had about roughly equal numbers of patients coming from metro, rural, or very rural areas. Slight majority were men, and then race mostly white. BMI approximately equal in all cohorts. When you looked at the statistical analysis for the type of tympanostoid, whether they presented and got a canal wall down versus an intact canal wall, there was actually no significant difference. There was only a 4% and 3% increase in likelihood to undergo a canal wall down in the rural and very rural patients, respectively, than their urban counterparts. And there was no difference in surgical time. In fact, rural and very rural patients were less than 2 minutes shorter than their urban counterparts for case times. So we looked at additional factors that could be associated with the rate of canal wall down, not just the rurality, but we found nothing. And then for surgical time, when we ran the additional factors that we collected, we found that the surgical time actually decreased by about 15 seconds for each additional year of age, and that men had surgeries that lasted on average about 8 minutes longer. So this is really interesting to me. For me, they refuted the traditional thinking that I had picked up in residency and or fellowship somehow. I don't know if this is any textbook, but you kind of go through your residency, your training, and your fellowship, and at least I got the impression, maybe falsely, that, okay, this patient is less likely to follow up, or this patient is less likely to have good long-term care because of where they're from, and therefore that might influence how we treat them. We might be more likely to treat them with a canal wall down, or I would think that this patient, is from a specific region, and therefore they probably just let this ear disease go and they didn't get it taken care of, and that's why they're here. And that's going to be a really big complex surgery to do because of that. And like I said, I don't know that anybody actually told me that, but it seemed to be some sort of unspoken thing that I learned. So that's why I was interested in looking at this. So, but this is not what I expected. I thought we'd find some differences, but basically it refutes, at least I'll say, my traditional thinking that patients requiring surgery from these socioeconomically and educationally disadvantaged areas required longer, more involved surgeries. And that's just not what we found. So the answer to this question is, surprisingly in my mind, the answer is no. So then I was, we got that published, and I was more interested in kind of retaining this analysis of surgical time and kind of moving on to look at some different questions. So to do this, we compiled a new database of chronic ear surgery, where we got almost 3,000 cases, about 1,500 tympanoplasties and about 1,400 tympmastoids. We had removed all the cases from this. So this is just with just those surgeries. So any surgery where you had a tympanoplasty on one side and an ear tube on the other side, or when you had a tympmastoid on one side, but they also had a rhinoplasty or tonsillectomy or something, all those patients were removed. So just these pure procedures. And there's variations within there. Some use cartilage, some may not. Some, there's variations here and there, and we'll talk some about that. But importantly, just we removed all those with multiple procedures, or operating on different sites, just to make sure we're trying to actually have more accurate case times. So when you look at the breakdown of these, we looked at primary versus revision. And we also categorized the tympanoplasties by post-auricular versus transcanal surgery, and the tympmastoids by whether they were intact canal wall or canal wall down. So this is just an overview kind of histogram of some of the breakdown of those main couple categories within each. When you look at our 1,500 tympanoplasties, you've got more primaries than revisions, which makes sense. And although there is a difference in surgical time, 112 to 103 minutes, no, it's not statistically significant difference. When you look at the approach, post-auricular versus transcanal, there's a lot more post-auricular than there are transcanal, and it won't come as a surprise to most people to see that there was a significant difference in median surgical time, with the transcanal surgeries taking less time. For tympmastoids, looking at primary versus revision, there was a statistically significant difference, with revisions taking much less time. I attribute this probably to second looks, which are going to have that yellow histogram there looks kind of right skewed to me. And so I attribute this to some second looks taking a long time because there's cholesteatoma left, and quite a few of them taking a short time. I don't do a lot of second looks myself, but my partners do a lot of second looks, and I know that when there's no cholesteatoma, it doesn't take too long. So that's, I think, one of the reasons for the difference between those primary and revisions. And then if you look at intact canal wall versus canal wall down, it was statistically significantly different, although I think because the N was so high, although the time difference was only 12 minutes there. So now we're going to get into a few of the different questions. I asked a few more questions from this database to try to just satisfy some curiosity that I had about different things. So the second question comes from an issue that I'm going to describe right now. This is Jackler's textbook. I love Jackler's textbook on otologic surgery. This is showing kind of what you should see when you're getting ready to do your tympanoplasty or your tip mastoid. You're going to visualize the ear canal, and this looks very well and good. And you're thinking, oh, I'm going to learn how to do this. I'm going to learn how to position this appropriately. But when you get into the operating room, at least when I get into the operating room, I more often see something like this. So this is a obese patient, and I don't know about the rest of the Eastern United States or anybody who's listening to this, or South Carolina, but Kentucky is a very obese state overall. This is the CDC information on obesity. And as you can see, Kentucky is firmly in the red. I see South Carolina down there in the red as well. My partner, Matt Bush, is from West Virginia. I always tell him, thank goodness we're next to West Virginia, because they are even redder than Kentucky. And it's always a little bit helpful when you can look around you and say, we're not the most significantly obese state. Now, it's not to say there's anything, intrinsically wrong with these patients. They deserve our compassionate care as well. But I do think it does have an effect on how you perform your surgeries. So I was really interested to look into some of this. Unfortunately, the next year the data came out, I wasn't able to talk to Matt about West Virginia, because Kentucky didn't even have enough data to submit to the CDC. So as we moved on, we're looking at question 2, does BMI impact surgical efficiency? And first of all, I want to kind of go over what metrics we used to calculate surgical times. You can do this from a variety of ways. First of all, you can look at incision time to close time, and that's what I call here operative time. There's data that shows that there's no association of BMI with increased operative time in otologic surgery. That was a NISQIP database study, and that was from 2018. So you've got that kind of on the one side. You've got a single institution study showing that operative times increased with BMI. And so those two are at odds with each other. The NISQIP database study was large. The single institution study was not nearly as large as the database that we had compiled here. So I thought this was a great opportunity to look at this. There is literature in general surgery and orthopedics that do show that there's increased operative time with increased BMI. So an area that's, I think, ripe for further research. You can also look at total OR time, which is your wheels in to wheels out time. And this takes into account your sleep and prep time, as well as your wake up time. And I call this the non-operative OR time. So we've got 3 different measures here: operative time, non-operative OR time, and their sum, which is total OR time. And that same institution that had looked at the previous study showed that non-operative times decreased with surgery done and an ASC, and increased with the use of a facial nerve monitor, but didn't find a difference for BMI. But as I said, not a huge N. So what metrics do we use to calculate BMI? I put this up here because this actually changed since I was in medical school. So now we have class 1, 2, and 3 obesity. So once you move past underweight, normal weight, overweight, it's just divided up by 5 unit increments of BMI: 30 to 35, 35 to 40, and then 40 plus. So if you look at tympanoplasty and BMI, this is just a general distribution of how many of our patients were normal and underweight, which is about 50%, and then the rest were overweight or obese. And when you look at operative time, just operative time by BMI, the second column, this beta column, is the change in minutes compared with a normal BMI. So normal BMI is our reference, and we're looking at the change. So statistically, we found that our operative time was greater in more obese patients. And then also interestingly, and this doesn't always bear out in all the other slides, but it was shorter in underweight patients, although not statistically significant. If you look at the non-operative time, OR time by BMI, actually, the time it takes to sleep, prep, and or wake up was greater in more obese patients. And then total OR time, a combination of those two. If we look at TIMP mastoids now, in fact, only about 35% of our TIMP mastoids are normal or underweight. So we've got 65% of patients here at UK who get TIMP mastoids who are overweight or obese. And looking at the operative time, only class 2 obesity showed a statistically significant operative time increase. If you look at the non-operative OR time, though, all the classes of obesity were taking more time to anesthetize or position or wake up. And then if you look at total OR time, it's more significant for the more obese classes. So some assumptions that we had to make to do those were that, one, BMI is independent of revision status, which I think is valid. Someone's BMI that I see in clinic doesn't determine whether I sign them up for a revision TIMP mastoid or a primary TIMP mastoid. That's decided by the care they had prior to seeing me. But the second assumption is that BMI is independent of the approach. So that's saying that I didn't take this person's BMI into account whatsoever when I decided whether I wanted to do a transcanal versus a postauricular tympanoplasty, or canal wall, intact canal wall, or canal wall down for a TIMP mastoid. And so I don't want to make the wrong assumptions. And I didn't feel like this was totally valid to do for every significant subset. I talked it over with statisticians. Statistically, we all know we shouldn't make multiple individual post hoc comparisons, even though in my head I wanted to see, does BMI affect this type of surgery? Does it affect this type of surgery? Does it affect this specific subset of surgery? But you can't really do that validly. And so it increases our chances of a type 1 error too much. So we talked it over, and we went with something that's called a mixed effects decision tree model. And this is a statistical method that where you plug in all your different variables, primary versus revision, you plug in your raw values for your BMI, and you look at your different approaches. So transcanal versus postauricular, intact canal wall versus canal wall down. And you see within this model, it's a iterative or recursive process where the variables that have the most impact on your dependent variable, which is your surgical times, the variables that have the most impact on that are the first split in this tree, and then there's successive splits that are less important for determining operative time. And then variables that are not sufficiently important to partition the data are excluded from the tree construction. So you won't see all the variables in all the trees. So when you look at surgical time, the first branch here is whether they had basically a TIMP mastoid versus a tympanoplasty, which makes sense, right? Tympanoplasties take less time usually than TIMP mastoids. If we go on the right side of this screen here, you'll see that the next most important thing was whether it was postauricular or transcanal, which also isn't totally surprising because we already saw that there was a difference between those two. But it was interesting to see that for the postauricular, but not for the transcanal, the BMI had an impact on surgical time. You can see, and again, this model has raw BMI values. So it's trying to find the exact cutoff of what's the most significant cutoff. And it found that 24.15 BMI. So that's about those who are overweight or normal weight versus those who are not. It was about 120 minutes for the postauricular tympanoplasties who were more normal weight, and then 128 minutes for those who were not normal weight. So then if you look at the left side, you're looking at the TIMP mastoids, and you've got primary versus revision as the number one, which, as we said, probably has something to do with the second look procedures. But if you look at primary TIMP mastoids, which is most of your initial cholesteatoma surgeries and some chronic otitis media, you're going to see that the cutoff, that BMI did have an effect on how long those cases took skin to skin. And for those that were in kind of the overweight or normal weight or underweight categories, it was 181 minutes. And those in the class 1, 2, 3 obesity was 190 minutes. So if we look at the non-operative OR time, none of those other kind of approaches made any difference. BMI was the number one thing that affected how much your non-operative OR time was. If you were in the classes of obesity or class 1, 2, or 3 obesity on the right-hand side, it found 34.35 BMI was that cutoff, the most reasonable cutoff here. Your non-operative OR time took 48 minutes versus if you were less, then it kind of divided it into these other two, which didn't seem to be that different, only 2 minutes difference, but 39 to 41 minutes if you're not obese, 48 minutes if you are. And then total OR time was just kind of some combination of those two, basically. So the answer to this question, does BMI impact surgical efficiency? Yes. For our cohort, it definitely did. Third question, let's get back to this picture. We walk into the OR, we get into this picture. Another thing that I think when I see this patient, or when I see him in clinic, I'm visualizing them on the operating room table. I'm thinking, man, that shoulder is going to be a bear. I'm right-handed. I've got partners who are left-handed. Matt Bush is left-handed. That is going to be a challenge for me because of their limited neck mobility. And frankly, this can be generous sometimes. You get in the OR sometimes and you don't even see that much neck. And you just dread doing right ears if you're right-handed, if you've got a patient that has this challenging of kind of a neck shoulder anatomy. So just like anybody with a left-handed partner, we've joked about me doing the complex left ears and him doing the complex right ears, and haven't actually done that yet. But I was really interested to know, does the handedness of the surgeon relative to the patient ear affect operative time? And so we've got, like I said, a handful of left-handed surgeons between otologists and pediatric ENTs who do ear surgery. And so we were able to basically take these 3,000 cases and divide them into kind of ipsilateral dominant pairings, or your hard pairings, like me operating on a right ear or a lefty operating on a left ear, and then contralateral dominant pairings, which are seen as kind of easier. And the nice part about this is that each surgeon serves as their own control. So I have about equal number of patients in this cohort as I do in this cohort. And so when you look at post-auricular tympanoplasties, no difference in surgical time between easier and harder sides. When you look at transcanal tympanoplasties, again, no differences. You look at intact canal walls, no difference. And you look at canal wall downs, no real difference either. So then I thought, but maybe, this is all comers, maybe just high BMI patients are going to show a difference between ipsilateral and contralateral pairings. And this is a busy slide, which you don't have to read, but basically there's no significant difference between these ipsilateral and contralateral pairings, no matter what their BMI is. Also, I should say that these decision trees, actually, we had put handedness as a variable into them, and at no time did handedness come into any of those decision trees as a significant effect on surgical, non-surgical, or total OR time. So as much as I dread doing some of those cases, statistically, it doesn't actually take us any more time to do cases that are right ears than it does left, or if you're left-handed, vice versa. So last question I wanted to look at was, what other factors affect surgical and non-surgical OR time? So if you look at the intra-class correlation of each of these variables, operative time, non-operative time, and total OR time, this statistic indicates the portion of variability that's explained by the surgeon. These are scatter plots of different surgeons showing kind of the distribution of how much time it takes them, surgical times on the left, non-surgical time in the middle, total OR time on the right. And this just gives you an impression of some people a little more right skewed, some people a little more left skewed, and it helps us helps explain visually some of the things that we see here. If you look at our ICC, you see for operative time, 70% of the variance in the operative time is explained by who your surgeon is. For your non-operative time, though, actually 51% of the variance of your sleep time, your wake-up time, is explained by the surgeon. And for total OR time, again, 72%. So what I thought is fascinating about this is that surgeons affect both the operative and the non-operative time. So something about the way that we're running our ORs, something about the way, are we more helpful? Are we less helpful? How are we setting the tone in the OR for more or less efficiency? I have a lot of thoughts on that, but I don't have data on it yet, so I'm not going to share them right now. So let's get to some of the limitations of these. Obviously, it's subject to biases inherent in retrospective studies. It's not stratified by OR location. We couldn't do this past our pre-EPIC data, which was 2021. So whether it's an inpatient versus an outpatient OR, that was not in this. I would say it's pretty non-generalizable. I think there's some things we can take from this, but man, having been at multiple different places to train, I feel like each OR is its own separate beast. I think it's very influenced by the facility, the personnel, the leadership, culture, teaching responsibilities, and then just some non-measurable factors. Chronic year data is very messy. This is why people like to study cochlear implants. We get percentages. Percentages are really nice in statistical models, but chronic year data is really challenging to parse out. Like even what surgery somebody had, they blend together. What the problem was. Well, it was a draining ear. Well, did it have cholesteatoma? Is it chronic otitis media? Is it granulation? Is it was a polyp? Like, what is it? It's very challenging to figure out what somebody had, what happened to them, and how you categorize them. Like nice, simple categories are hard to draw. So that's what makes this so challenging to study. Patient and surgeon thresholds for surgery are pretty variable. So you could have two separate patients with the same problem, and they might choose different courses forward with the same surgeon. And likewise, you could have the same patient see two different surgeons and get two different surgical plans. So that also makes the data set somewhat heterogeneous. I did my very best to try to draw the most obvious, most reasonable lines between categories as I could, but there's just inherent variability there. And then the extent of disease is variable too, right? You have a cholesteatoma A and cholesteatoma B, and they could be, on opposite ends of the spectrum. So those are certainly some of the limitations that we faced here. And then from a conclusion standpoint, for question 1, rural patients with cholesteatoma are no more likely to undergo longer or canal wall down surgeries than metro patients. Operative time, non-operative time, and total OR time increase with BMI and chronic ear surgery. Despite finding ipsilateral to Hannidus ears more challenging, personally, I don't know if that applies to everybody, but personally I find them more challenging. Surgical time is no greater than with contralateral two-handedness ears, even in patients with a high BMI. And then individual efficiency as a surgeon accounts for 50 to 70% of the variance in all of the different OR times that you can measure. As a junior faculty, I like to say that my future directions is probably as long as the whole paper itself, just because there's so many different ways that you can take these things, and you have so much time that you have to be able to devote to these. So I want to drill down on some specific aspects of surgical, non-surgical time. So what's value added, what's non-value added. I'd like to investigate the effects of more or less efficient anesthesia providers, scrub techs, things like that. And then evaluate the ergonomics of operating on the obese. I think we could explore the effects of different level residents on OR times, which may be surgeon specific, but I think could be interesting. I'd like personally to focus on, and I already do this to some extent, obviously, because it's an interest of mine, but I like to personally focus on efficiency a little bit more, maybe for some of our upper level residents who already know how to do some of these things, and I'm always pushing them to do what they can do and cut out non-value added time. But